Hello everyone and welcome to another session of Next Saviours Essential Question Series. Today we are going to have a discussion on hematuria related questions. What are the common causes which are kept in the examination for the purpose of its identification, particularly the UTI, the bladder cancer, the urolithiasis, and renal cell carcinoma. These are the commonly kept topics for which hematuria is usually asked as a differential diagnosis. So let's see how to approach to the diagnosis of the individual one. The first question is a 28-year-old sexually active female presenting to the OPD with a complaint of burning micturition. So that is the first hint which is provided to you. Now, there is a history of increased frequency of urination and lower abdominal discomfort for the last 2 days. She also reports seeing blood in her urine on 2 occasions. That means there is a history of hematuria presented to you. Now, she denies any fever, there is no flank pain or vaginal discharge. She has no significant past his medical history on examination. The temperature is normal, the pulse is slightly raised, and there is mild suprapubic tenderness. There is no costovertebral angle tenderness, and urine appears cloudy, but there is no foul odor. So, what is the next best investigation to be done in this case? So, this obviously is a feature which is suggestive of lower urinary tract infection of uncomplicated nature. So, what are the hints? What are the features of lower urinary tract infection of uncomplicated nature that you have to remember, which will always be provided to you in the question? The first one, obviously, is the dysuria. It is the burning sensation during urination, and it is considered to be the hallmark for the lower urinary tract infection. So, always and always, this as a clinical feature will be provided to you. Next is increased in the frequency of urination because there is urge of to because there is increase in the urge to urinate with the small volumes, which is another clinical feature. Now, suprapubic tenderness, which is localized discomfort in the lower abdomen, which is again common in case of cystitis. Cloudy or foul smelling urine is a feature which is suggestive of infection and pyuria. Now, in our question, there is no foul smelling urine. That means it could be UTI, but not the complicated one. Hematuria, which could be gross or microscopic, that means blood is seen in the urine. It may be terminal hematuria at the end of the stream, which is a common feature of UTI. And yes, UTI is considered to be the most common cause of hematuria overall. Apart from this, there are other features of any infection, like there will be low grade fever, which may occur in uncomplicated UTI. High fever is suggestive of upper urinary tract involvement. Then there will be leukocyturia and bacteriuria on urine analysis, which is confirmatory evidence of infection. And this is exactly what we want to have as the next set of investigations. The presence of the nitrite positivity on dipstick is suggestive of gram-negative organism, particularly E. coli, which is a common cause of lower urinary tract infection. The history of recent sexual activity, particularly in females, predisposes a patient for the urinary tract infection. And if there is a presence of no sign or systemic illness or flank pain, then it is helpful for differentiating from pyelonephritis or the glomerular causes. Because this is how the clinical features of the urinary tract infection as a cause for the hematuria could be kept in your question. Now, if you go back to the question, so here there is a classical presentation of uncomplicated lower urinary tract infection. That means cystitis in a young woman. So the most appropriate initial investigation obviously is urine analysis. Now, what you are going to get in urine analysis? It is a dipstick test for the leukocyte esterase and nitrites, then microscopy for WBC bacteria and the presence of the RBCs, and finally the urine culture in order to identify the pathogen and antibiotic sensitivity. So urine analysis is considered to be the best answer among the options. Why not the other options? Like if you go with the renal ultrasonography, now it is usually done in case of upper urinary tract infection, which could be pyelonephritis, or if the obstruction in the urinary tract is suspected. So it is obviously not indicated in uncomplicated UTIs. Another option is contrast enhanced CECT of the abdomen and pelvis. You see, it is reserved for the cases where the patient could be suffering from complicated UTI, the renal stones, abscesses, or if there is no improvement with the management of the suspected UTI. But obviously, it is unnecessary at this point. And finally, the cystoscopy is an invasive investigation which is used to evaluate the hematuria of unknown cause or in case of bladder carcinoma. So it is not appropriate as a first line in young patients with obvious infectious symptoms which are provided to you in the history. So best answer for this question is urine analysis for urine microscopy and culture. So this is how the questions of UTI could be presented to you in examinations. Coming on to the next set of the question for bladder carcinoma. So how the question related to the bladder carcinoma would be projected? A 65-year-old, that means elderly individual. That is one hint provided to you. Second, a chronic smoker. This is a second hint provided to you because it is a most important risk factor associated with the bladder carcinoma. Now, presenting with painless visible hematuria for the past 1 week. And yes, painless visible hematuria is considered to be bladder carcinoma until proved otherwise. So this is the third most important hint provided to you in the question itself. Now, apart from this, everything is negative. Like there is denial of dysuria, fever, or flank pain, no history of trauma, no history of recent infection or anticoagulation. The physical examination is unremarkable. Blood tests are within normal limit. Urine analysis confirms hematuria without significant pyuria or proteinuria. So what is the next best investigation in this patient? So obviously you came to know that the patient is suffering from the carcinoma bladder and how the features of the carcinoma bladder are usually kept in your question. The first one, as we have already talked about, is the painless gross hematuria. You see, it is the most common presenting symptom which is considered to be the hallmark of the bladder cancer and is considered to be the question related to bladder cancer until proved otherwise based on this clinical feature. Second is the hematuria which occurs throughout the urinary stream. You see, how is it different? Because it is suggestive of the bleeding from the bladder rather than the urethra, because in case of urethral bleed there is going to be a terminal hematuria, not throughout the urinary stream. Third point is recurrent hematuria. That means especially in the absence of the infection or in trauma, if the patient is having a recurrent hematuria, then it is again pointing towards the bladder cancer. Now, absence of the dysuria or fever, if at all, is coupled with these three clinical features, then it is again pointing that then it further narrows down the differential diagnosis, that it on the basis of which the UTIs can be ruled out or the stones can be ruled out. Then the specific clinical features like irritating voiding symptoms where there is increased frequency, urgency, nocturia, especially with the carcinoma in situ. If the patient is old age, more than 50 years, because the peak incidence for the bladder cancer to happen is in the 6th and the 7th decade of life. Male gender are more predominantly affected because the male to female ratio is almost 3:1. The history of smoking is considered to be the strongest risk factor for the urothelial carcinomas. The other occupational exposure could include the aromatic amines, and no improvement with the antibiotics could also be a feature added to your question because it rules out the infection related hematuria. So I hope that you would be able to identify any question related to the bladder cancer, if at all asked, in relation to the differential diagnosis of hematuria. Now, if you go back to the question that the patient is an elderly male with a painless gross hematuria, which is bladder cancer until proven otherwise, as a result of which the cystoscopy is obviously the gold standard and the first line investigation to directly visualize the bladder mucosa and identify the suspicious lesion or the tumor, if at all, could be seen. So biopsy can also be taken during the same procedure if you can visualize the lesion on the cystoscopic examination. Now, why other options are incorrect, like the urine culture and sensitivity is useful when the urinary tract infection is suspected. Ultrasonography of the kidney, ureter, or the bladder is a non-invasive and it might also result in the visualization of the masses, but it is not sensitive for flat or the small bladder tumors, for which especially you have to go for the direct visualization under cystoscopic examination. And finally, CT urography is excellent for evaluating the upper tract malignancies and even staging, but cystoscopy still remains the first diagnostic step in suspected bladder cancer. So this is how the question related to the carcinoma bladder, a key clinical one. First, you are asked to identify that the question is related to the bladder cancer. What is the best investigation to continue with? Now coming on to the next reason, that is lithiasis. As now coming on to the next cause, that is lithiasis for hematuria, and how the question is framed related to this. A 35-year-old male presenting to the emergency department with the sudden onset of severe right-sided flank pain, which is radiating to the groin. So when you see this kind of the hint, you obviously are aware that the question is asked in relation to the stones. Now, the pain is colicky in nature and is associated with nausea and vomiting, which is again a contributory sign that the patient could be suffering from the stones or the impacted stones. Now, he has had a similar episode of 2 years ago, which resolved spontaneously, which is always present in these kind of the patients as a third hint. He denies any fever or urinary symptoms. That means there is, to some extent, you can rule out that the patient could be suffering from the urinary tract infection. Now, on examination, he is restless, afebrile, and mild right costovertebral angle tenderness. The urine analysis reveals microscopic hematuria and no signs of infection. What is the next best investigation to confirm the diagnosis? As you know, that this is the question which is asked in relation to the stones. So, if the patient is having a, so what are the likely clinical features kept in the questions related to the urinary tract stones are the severe colicky flank pain, which is of sudden onset, sharp and intermittent, and it may cause the patient to be restless or unable to lie still, which is in comparison to other acute abdominal features like appendicitis. Second is that the radiation of the pain to the groin or scrotum or labia is suggestive of that the stone is lying in the ureter, and due to the referred pain along the genitofemoral nerve, it is being sensed in these areas. Next, the presence of the hematuria that could be gross or microscopic, which is seen in 90% of the cases, which is typically microscopic until there is a trauma from the stone movement. Apart from this, very important clinical feature is the restlessness or constant movement of the patient. And you know, this is how it is differentiating from other abdominal causes like appendicitis or cholecystitis, where the patient lies supine. Now, nocturnal awakening with the pain because of the sudden sharp pain can disturb sleep, and renal colic in particular is notorious for this. Now, associated nausea or vomiting is due to the visceral pain reflex because of having a shared innervation with the GI tract, which is again a very important associated clinical feature related to any urinary tract stone. There is no fever in uncomplicated cases until and unless it is superseded with the infection. So presence of fever is suggestive of added infections like pyelonephritis or obstructive pyelonephrosis. There would be a presence of the costovertebral angle tenderness, which is found on physical examination, typically on the side of the stones, and previous history of the renal stone is very, very strongly present. It increases the suspicion. Recurrence is very, very common in these sort of the patients. So this is how the clinical features related to the urinary tract stone as a cause for the hematuria, this is how it is going to be kept in your examination. Now, if you go back to the question, the patient has a classical feature of the renal colic, most likely due to urolithiasis. The most sensitive and the specific test to confirm the diagnosis and localize the stone is non-contrast CT KUB. Why? Because it detects more than 95% of all the types of the stones except some rare radiolucent stones like Indinavir stones. And second, that they are fast. It's a non-invasive investigation and gives the exact location along with the size of the stone. Now, why other options seems to be incorrect? Although ultrasonography is the first line of investigation to be used in case of pregnancy or in case of children, but it is having a limited sensitivity in detecting ureteric stones and small calculi. So that is the reason why it can be ruled out. IVP is obsolete and is largely replaced by NCCT due to the radiation risk and contrast nephropathy. So it requires functioning kidneys and good GFR. That is why it is also ruled out. And finally, urine culture is useful whenever there is a suspicion of infection, but it is obviously not diagnostic for the renal stones. And then finally, how the questions related to the renal cell carcinoma as a cause for hematuria are kept, or what is the language for the purpose of its identification kept in the examinations. A 60-year-old male chronic smoker presenting with the complaint of painless hematuria for the past 2 weeks. So it is all again goes in the favor of carcinoma. It could be renal cell carcinoma or it could be a bladder carcinoma. There is no differentiation till this point. But he is also reporting of a dull left-sided flank pain. Now, when you have started adding this flank pain as a specific feature in this history, the things are going to take the another turn. And the feeling of heaviness in the abdomen. Now, there is no fever or history or UTI on examination. The palpable non-tender mass is felt in the left flank region. So this much is more than sufficient for you to reach the diagnosis that possibly this time we are dealing with the question related to the renal cell carcinoma. Now the blood pressure obviously is found to be elevated. Urine analysis confirms the microscopic hematuria and the basic blood investigations are within normal limits. So what is the next best investigation to confirm the diagnosis? So you see the clinical features that suggest that the patient could be suffering from renal cell carcinoma in this question related to hematuria are the painless hematuria. As you know, it is a classical presentation for the cancer. Flank pain, it is usually dull or persistent, unlike the colicky pain of the urolithiasis. There is a palpable flank of the abdominal mass, which is a late feature, which could be firm, non-tender, and palatable. The left-sided varicocele that could be sudden onset, non-reducible. It is due to left renal vein invasion or obstruction, which is another very specific finding for renal cell carcinoma in the form of its complications. There could be unexplained weight loss and fatigue along with the fever of unknown origin as constitutional clinical features. There is a presence of the hypertension because of the excessive renin release or renal ischemia from the tumor mass. There is polycythemia from paraneoplastic erythropoietin production, which is seen in around 5 to 10% of the cases, which could be an added clinical feature kept in the question related to RCCs. Apart from this, there could be anemia, which is also a possibility due to chronic blood loss or bone marrow suppression. Hypercalcemia is a feature because of increased parathormone secretion, which is because of the increased parathormone secretion, and hepatic dysfunctions identified as Stafford syndrome, which is actually a non-metastatic hepatic dysfunction, which is specific to the renal cell carcinoma. So these are the clinical features which are suggestive that the question could be asked from the topic of renal cell carcinoma. If you go back to the question, this is a classical presentation of how the RCC is present because it is composed of a triad. One, the hematuria, the presence of the hematuria. Second is the presence of the flank pain. And third one is the presence of the abdominal mass. Although this triad is seen in minority of the patients, like up to 10% of the patient, but it is highly suggestive if at all it is present. Now, out of the multiple investigations provided in the options, it is the contrast enhanced CT scan of the abdomen is the next best investigation because it gives the excellent visualization of the renal mass. Second, it also helps in determining the extent of the tumor, renal vein, or inferior vena cava involvement. Then, it is also useful in the assessment of the lymph node invasion and possible metastasis. And obviously, it aids in the surgical planning, which could be achieved by partial or radical nephrectomy. So, that is the reason why contrast enhanced CT scan of the abdomen is the next best investigation if at all the renal cell carcinoma is suspected. Now, why not the other options? As you know, that urine analysis and culture is useful in case of UTI, but the presence of palpable mass, painless hematuria, it is pointing away from the infection. Then second is ultrasonography of the abdomen obviously is a good screening tool. It might also even detect a mask, but it is not sufficient to evaluate the extent or the vascular invasion. And due to these limitations, CECT is superior to USG. As far as this MRI of the abdomen is concerned, it is reserved for the cases where CT contrast is contraindicated. Like if the patient is having a renal impairment, if the patient is having contrast allergy, or for better vascular detail. But obviously, this MRI of abdomen is not the first line of investigation for the detection of the renal cell carcinoma tumors. So I hope you have understood that how the clinical features related to the four most important causes kept in your examination for hematuria, that is urinary tract infection, the renal cell carcinoma, the urolithiasis, and bladder cancer, are kept for the purpose of its identification. All the best for your future examination. Thank you for listening the lecture. In order not to miss any update, please join our Telegram group. The link is provided to you in the description.